Hi guys, welcome to Medstudent Notebook. This is episode 1 and we are going to be talking about Fournier's gangrene. Please note this is an average Nigerian medical student trying to explain her class notes in order to help other medical students understand better. So please do read your own class notes and other resources for further details, okay? So today we are going to be talking about Fournier's gangrene, and I'm sorry I'm starting off very strong. It's because this is the first thing we are taught today and I decided to just explain it to help me recall better. So this is going to be our outline. Please note you have the right to use your own outline for better explanation. So the first thing we are going to be doing is the introduction and then the risk factors, and after that we'll go into the pathogenesis, the clinical manifestation, the diagnosis and the treatment. Okay, so first of all, let's start with what Fournier's gangrene is. First of all, let us know that there is a difference between cellulitis and necrotizing fasciitis. Okay, so there's a difference between cellulitis and necrotizing fasciitis. Cellulitis is when you have something like a bee sting or an injury or an inflammation on your skin. That is cellulitis. But when you add cellulitis plus cell death, it becomes necrotizing fasciitis. Okay, so where are the places we see necrotizing fasciitis? Different forms of it, that is what I mean. We have the Fournier gangrene. Okay, and then we also have the cancrum oris, which can happen in the mouth, that is the cheek. And then we have the meleny, which happens in the trunk, in the abdomen, GI. Please, you guys confirm this. But these are the forms of Fournier gangrene. And Fournier gangrene, it is called Fournier because it involves the male genital tract, the male perineum. Okay, but when it happens in the females, it is called necrotizing fasciitis. It is not called Fournier's gangrene. It is called this. Okay, but because it is a male organ that is affected, the male scrotum and all of that, it is called Fournier gangrene. Okay, so now let us go into Fournier gangrene properly. What happens in Fournier gangrene is that this is why it is called necrotizing fasciitis. Let's say we have the skin, so this is the skin, and let's say we have the testes, and let's now say on top of these testes, the fascia covering it is called the tunica vaginalis. So why it is called a necrotizing fasciitis is because this space between the skin and the testes, I'll have to use a different color, between the skin and the testes is a fascia. All right, and now a fascia is because it is between the skin and the testes. So if there is any type of inflammation and infection and dead cell tissue, right, occurring in between this place, it is called a fasciitis. And because a tissue is dying, it's not just cellulitis, a tissue is actually dying. In fact, not a tissue, connective tissues are actually dying. We will now have to add necrotizing on top of it. Okay, so let us get that into our head. Let us know that in necrotizing fasciitis, directly we are referring to Fournier's gangrene. The skin is not affected. The testis is not affected. The tunica vaginalis is not affected. But then the top of the tunica vaginalis and below the skin is affected. So this whole place, all the connective tissues, all the structures in between here, I'm going to color that red because those are the areas affected. The skin, the testes, and the inner part of the tunica vaginalis is not affected. So please note that, okay? So now, we are still in introduction. So by way of definition, we can say that Fournier's gangrene is a form of necrotizing fasciitis that occurs in the male genital tract. Okay, so this is a basic definition. Please note that you have to read further to get a very detailed explanation, but this is just basic knowledge. So now, having said that, our next outline is risk factors, okay? So our next outline is risk factors. So by saying that, we are going to talk about the risk factors of Fournier's gangrene. One, we have older age. It can also happen in younger people, but older age, and we are referring to males, of course, because Fournier gangrene, like I said, is a male disease. So male, in quotes. And then another predisposing factor, risk factor, is diabetes mellitus, okay? Another predisposing factor is if you have immunosuppression. All right, because if you have immunosuppression, the bacteria that is going to cause this Fournier gangrene would have a very wide space to thrive. And then another risk factor we can have is poor hygiene. Wearing boxers for a very long time, 1 week you're not changing your boxers and all of that. Another risk factor is trauma. Okay, when you have a trauma to the perineum, to the testes, the area of the perineum, the male genital tract, the penis and all of that, just that whole area. And maybe even if it's trauma by fall, by scratching, by injury, by surgery, anything that would cause a breach in the skin of the perineum is a risk factor. Okay, so imagine you do not change your boxers and then you still itch on top of it. These are our common risk factors. So it is not hereditary, so it is not genetic. So genetic whatever is not a risk factor. All right, so now on to our next subtopic. We have the pathogenesis. Now, when we are talking about the pathogenesis, we want to know how this Fournier gangrene occur. So let's say this is the skin, right? This, the skin. If there is a breach in the skin here, so this red arrow signifies the breach, right? And if there is a breach in the skin, what you are going to expect is that bacteria would, I'm going to color bacteria green because they are living organisms. So bacteria would come into this breached skin. Now I know the question you're asking, what kind of bacteria? Is it aerobic? Is it anaerobic? The first thing first is that this Fournier gangrene is a polymicrobial infection. That could also be your definition. It's a polymicrobial infection. It is a polymicrobial necrotizing fasciitis. All right. So now, when this anaerobic organism enters into the breached skin, first of all, I mean aerobic. If I said anaerobic, please discard that. I feel like I said anaerobic. First of all, the aerobic goes first. So aerobic. They enter into this breached skin and they start causing digestion of the connective tissue. They will cause digestion of the connective tissue. So these are all the connective tissues. And please note, the testis is still here. And then the tunica vaginalis covering it. So don't worry, the testis is good to go. It is not affected. Okay, so the testis not affected. So now, when this organism enters into, when there is a breached skin, whether by scratching, trauma, whatever, immunosuppression causing more infections and all of that, once the aerobic organism enters into the breached skin, it will start causing production of collagenase. So the first thing it to produce is 1, collagenase, and then the next thing it to produce is 2, fibroelastase. So anything that is going to cause breakdown of connective tissues, it is going to release it. And once it is being released, what are you going to see? All these things are going to start breaking down collagen, fibroblast, every single thing. And now when it starts breaking it down, what is going to happen? It's going to create what am I going to call it? It's going to create an anaerobic environment because it is causing ischemia. So when ischemia is occurring, dead tissue and all of that, it's creating an anaerobic environment, and that is where anaerobic organism comes in. So 2, anaerobic organism. Now, these anaerobic organisms are the ones that now compound it. They make situations worse. Why do I say that? So aerobic organisms have entered, good, fine, no wahala. But now anaerobic organisms coming, I'm going to indicate them with the yellow arrow, go into this breached skin and start causing further damage. So they go in and start causing further damage. Now, how do they cause this damage? I'm going to show you guys in a bigger screen. So now for this further damage, I'm going to circle it and bring it here. When these anaerobic organisms come in, they start causing what is called the blood vessels, right, that supply this whole area, right? The blood vessels that supply this whole area is going to be cut off. So this anaerobic organism, which I'm going to be indicating by yellow, is going to cut off blood supply to the skin, to the connective tissues to this area. And once it cut off blood supply, what is it doing? It is further increasing anaerobic environment, making more anaerobic organisms to come in. Please note that this is a polymicrobial. So both aerobes, anaerobes, every type of microorganism is permitted to thrive here. Another thing I want us to note before we forget is that based on the risk factors, Fournier's gangrene can be gotten from outside the body and inside the body, okay? So now let's say we have okay, I'm going to use a new page for that. If we are suspecting a gram-negative organism, that means we have to add urethral strictures to one of our risk factors, okay? So now, gram-negative organisms, you are going to suspect if the microorganisms are coming from 1, urethral strictures, 2, postrate CAs, okay? You suspect gram-negative organism. But trust me, when you have a Fournier gangrene patient, the first thing to do is not to even start trying to culture, because it is very hard to culture that organism. I'm just trying to say things that can make you suspect. But now, it is gram-positive, or rather, you should suspect gram-positive organism if it is coming from either the GI or the outside environment. By outside environment, I'm talking about the boxers and dirty environment, scratch, trauma, etc. So this is what we should suspect. So back to what we were doing before. Okay, so now, like I said, remember, let us recap. The skin is breached. All right, if the skin is breached, if the skin is breached here, we are expecting an aerobic, forgive me for always saying anaerobic, an aerobic organism to go in first. When they go in first, they start producing collagenase and other lytic enzymes are going to break down the connective tissue. And once they are done with that, an ischemic environment is created. And once the ischemic environment is created, the anaerobic organism will now have the audacity to go in and start doing more. Now, what does this anaerobic organism do? They cause more, they cause thrombophlebitis. That is what we are going to call it, because now the small blood vessels that are supplying these connective tissues are cut off. And when blood supply is cut off to a particular thing, we obviously expect one bad thing to occur. This bad guy, death, occurs. Now, it's now that death that manifests as a decay. So what we see it as is a decay. So I'm going to add this image. This is what we see it manifest as, a decay. So look at these testes, right? This testis is black. It is a gangrene. It is turning black. And it can even be so bad that it will extend into the upper stomach, the lower stomach rather. So this is the lower stomach. It can go up. All right, viewers' discretion is advised. I'm sorry for saying that even after showing the image, but look at how bad it can get. Okay, so please change your boxers, avoid trauma. If you have any boil, anything, make sure you treat it with care. Don't allow any breach in your skin in these sensitive places. Okay, so now having said that, let's go back to our outline. We are done with our introduction. Okay, we are done with our introduction. We are done with the risk factors. And we are still under pathogenesis, right? I've not really explained the pathogenesis very well. So now this is what happens. Back to where we were. Once these Fourniers, these bacteria enter inside, they start digesting every single thing here, cause ischemia, anaerobic organisms enters, cause more damage, cause more ischemia, and cause thrombophlebitis. I'm going to write it here. Thrombophlebitis. Now, when all this occurs, right, you would see that something very pathologic or something very significant of Fournier's gangrene is going to occur, and this is called the putrid smell. All right, so this putrid smell, I'm going to tell you how it happens. So of course, anaerobic organisms, they break down a lot of things, and when they start, something is produced. Of course, when you see the connective tissue, which obviously contains protein, being broken down, they will release something called sulfur. All right, we obviously know that sulfur is contained in proteins. Now, when this sulfur is released, we are expecting H2SO4, which is a very bad solution. Now, this H2SO4 is what is now going to cause the very pungent, putrid smell. Now, this pungent, putrid smell is what makes Fournier's gangrene. And that is because it is, in fact, this putrid smell is what makes Fournier's gangrene a clinical diagnosis. Because once you perceive this putrid smell from the perineum, right? The putrid smell oozing out, very, very smelly. The human nose is going to be very, very affected, okay? So once you start perceiving this putrid smell, we are going to most likely suspect Fournier's gangrene. Why? Because it is caused by the anaerobic breakdown of these proteins, releasing what? Sulfur. And when sulfur is released, H2SO4. And when H2SO4 is released, we're expecting that putrid smell. Now, this does not end, because if it is not treated on time, it continues to extend and extend and extend until you are seeing, like we showed in this diagram, until you are seeing the lower stomach affected. It can even affect the thighs or whatever. If you Google Fournier's gangrene online, you are going to see so many images of so many places that can be affected around the perineum. So that is that for the pathology. Right? So we are done with pathology, so we can tick it 2 times. So tick. Now we are talking about the clinical manifestation next. So for the clinical manifestation, what are we saying? Clinical manifestation, we have a lot of systemic features. Of course, we know that Fournier's gangrene is an inflammatory process, necrotizing fasciitis. Anytime you see itis to the end of something, itis, we're already expecting it to be an inflammatory process. So what are the systemic features of inflammation? Apart from the cardinal features of inflammation we know, which are redness, pain, redness, which is rubor, pain, swelling, which is tumor, and there's one more thing: redness, pain, swelling, and heat, exactly, which is calor. So rubor, tumor, calor. I'm still trying to remember what pain is, that ends with or, but rubor, tumor, calor. All right. So apart from these cardinal features of inflammation, we have some systemic ones, and these systemic ones can be obviously fever. 1, we can have anorexia, we can have fatigue, we can have vomiting, we can have tachypnea, that is breathing too fast. We can have tachycardia, that is increased heartbeat, okay? We can also have weakness, and in severe cases, confusion and death. All right? But if it is detected very early and treated, death would most likely not occur. So these are the features. Now, when we get to treatment, we are going to say that, all right? So we are done with the manifestations, the clinical manifestations of Fournier's gangrene. So we have to tick this one double. All right. Okay, I have to use red, double. Now, let's go to the diagnosis. Diagnosis of Fournier's gangrene is mostly clinical. So once the patient presents to the clinic and the person talks about his history, and we are seeing that, okay, this person probably has diabetes mellitus or has an immunosuppressive condition or all of that, and you now open the person's perineum, tell the person to expose himself, you are going to perceive that putrid smell, and once you perceive that putrid smell, you know it is Fournier's gangrene. All right. Now, it has that putrid smell, which is a typical smell of dead necrotic tissue. That is why we call it a necrotizing fasciitis. All right. Now, we have two grading systems. The first grading one is the Fournier's gangrene severity index. You can read up that one. So Fournier's gangrene severity index, and then, okay, that is the first, not the second. So the first is Fournier's gangrene severity index, and then the second is the Udulag grading system. All right. So in these systems, you can use the temperature of the patient. Forgive me, one of the clinical manifestation is increased temperature. We're obviously going to see that in fever, right? So we are going to check the temperature. We are going to check the serum electrolyte urea creatinine level. We are going to check the pulse rate. And we are going to check, of course, we're expecting to check the white blood cell count since it's an infection, right? So these are the ways you are going to use to grade it. So if you cannot just come and say Fournier's gangrene. You have to say something like Fournier's gangrene grade, maybe grade 3, grade 4, or whatever, depending on what you use to grade it, right? Whether you're using the FG severity index or the Udulag grading system. Now, there's another thing we should know. In as much as Fournier's gangrene has clinical diagnosis, you can also do some CT scan. And why are we doing CT scan? To check the extent of the Fournier's gangrene. So you can either do CT scan, you can do swab culture to check the microorganism, which is not so advisable because, like I said, it is polymicrobial, meaning there are so many microorganisms that can cause it. So you can obviously start with wound treatment before you even start checking the swab to be sure of the microorganism. And now, when you are even checking this microorganism by microbiology, MCB, remember to transport it, because we are actually interested in the anaerobes, right? So it has to be transported in an anaerobic medium to the lab, because if you transport the organism, the culture, right, in an aerobic medium, you are going to expect the anaerobic organisms to even die before you start checking what organism it is. So an anaerobic medium is preferred over an aerobic medium. So that is that. Another thing we have to do now is the treatment, because I think that is the last one. We are done with the introduction, the risk factors, the pathogenesis, the clinical manifestation, the diagnosis, and now the treatment, which is where the main point lies. So for the treatment, let's go. For the treatment, we can have medical treatment and we can have surgical treatment. Whenever you are writing a short note, if you can divide your treatment into medical and surgery, it is good. There is nothing like conservative treatment. Please, it is not allowed. All right. So now for medical treatment, of course, we expect it to be broad spectrum antibiotics. So we are talking about the medical now. We're expecting it to be what? Broad spectrum antibiotics until you eventually culture and figure out the one causing it, even though, like I said, it's polymicrobial, so many things can be causing it, but broad spectrum antibiotics. If the person is antibiotics resistant, please start wound healing until you finally figure out what antibiotic to use. All right. Now, for the surgical treatment, most times they actually need immediate surgery, right? And then they need what they call debridement. So I'm in the surgical treatment now. So for surgical treatment, I have to use blue for this one. Surgical treatment, one, we have debridement, but not just any debridement, radical debridement. Why? Because we need to remove all the edges of the cell, right? We need to remove all the edges. We have to cut off all the necrotic tissue until we see free bleeding. So what do we mean by free bleeding? Let's say you're cutting off the necrotic tissue and then you now see small blood coming out, oozing out. Remember, imagine you prick yourself with a blade, and that kind of capillary flow that is achieved, that is what we mean by free bleeding. All right. So now, when that radical debridement occurs, there are now other processes that follow after. So after radical debridement, first thing you have to do is to wash the solution with hydrogen peroxide. Why? Because hydrogen peroxide has a high amount of oxygen. And remember, what are we trying to kill? Anaerobic organisms, right? So imagine using an aerobic solution, which is hydrogen peroxide, to wash off that injury, right? Of course, you're expecting the anaerobic organisms to die, right? Now, after doing that, after washing with hydrogen peroxide, you can now wash with a solution like Savlon, all right, or normal saline. You can now rinse off with normal saline. Now, when you do that, you will now use a chemical dissolving agent to clean the wound. Now, an example of a chemical dissolving agent is honey gauze. That is the most accepted right now. There's another one we know, which is not really in use in UNTH, and that one is EU Sol. There's a full meaning, check that out. So these are the things you can use for the chemical dissolving. So after radical debridement, you wash. Okay, so these things are actually supposed to be numbered. They're not really under radical debridement. After radical debridement, you clean with H2O2, and then you rinse with normal saline, and then you do sloughing, chemical disloughing with honey gauze, more acceptable. Now, why are we using honey gauze? This is because honey gauze is osmotically what? Active. So there's increased osmosis in the honey gauze. So it's going to drag in water, fluid, and everything from the injury to itself. So honey gauze is osmotically active. So it's going to be dragging in H2O to itself. So let's say this is the honey gauze. It's going to be dragging in H2O, water, to itself because it is osmotically active, causing an increase in wound healing. So this is our treatment, medical, surgical, blah, blah, blah. Now, the final step is that you can now use, I'm going to number it 5. You can now use iodine, but iodine is usually used when the wound is now cleaned out and when you can see a granulation tissue. We're going to talk about granulation tissue in our next topic. So that is when you use iodine. All right. So now, another thing we need to note about this Fournier's gangrene in summary. Okay, so this is our summary. We did not include it in our outline, but please note this is our summary. So another thing you need to know in Fournier's gangrene is that the source of the organism, if identified, is tackled. All right. And now, for example, another thing you should notice, let's say you realize that, what is causing Fournier's gangrene is UTI, a urinary tract infection causing bacteria and all of that. What you need to do is to divert that urine. So you can do a suprapubic cystectomy. So if you do a suprapubic cystectomy, you would divert the urine. I'm going to indicate urine with yellow. You're going to divert the urine over the pubic symphysis. So let's say now there's a UTI in this place, right? So you just divert it to the upper part of the pubis, and then the urine is going to flow through another outflow, right? So you're going to now free this whole area from getting more infected. Okay, so you have to divert that urine, because if you are treating the Fournier's gangrene and you're not diverting the urine, it's going to keep on recurring. Another thing we should note, so this is the first thing, another thing we should note is that you can give a tetanus immunization, all right, especially if you are suspecting that, oh, I'm cleaning this wound, it's not getting better. Give a tetanus immunization, okay, especially even if it's through trauma. All right, now when the granulation tissue has been formed after all your debriding, washing off with H2O2, that is hydrogen peroxide, rinsing with normal saline, and then chemical disloughing with the honey gauze, and then covering with iodine and all of that, you can now do what they call wound cover. All right, and by wound cover, I mean you can either use one split skin grafts, where you collect the skin from any part of the body. Remember, a graft does not have blood supply, while a flap has blood supply. So you can either do split skin graft or flap, or even before any of that, you can just oppose the wounds. So I'm going to call this opposing the wounds 1. That is, you will just raise up the skin and stitch the area, especially if the exposure of the Fournier's gangrene is small. So oppose wound. If the apposition of wound cannot work, and suturing it, if it cannot work, maybe because the area is large, or maybe you just cannot, maybe the whatever, you can now do split skin graft, or you can do flap. Flap is the one that has what? Blood vessels. Okay, so those are the things you need to do. All right, so it is based on the size. If it is a small wound, let's go for opposing the wound. If it is a big wound, but you can actually deal with a split skin, then you go with a split skin. And then if it is a deep wound that needs neovascularization, you use flap, because flap has blood vessel. But the flap has to be somewhere close in anatomical position to the site of injury, that is to the site of Fournier's gangrene. All right, guys, Medstudent Notebook is done, and I really hope you guys understood this. Let me know what other topic you want me to talk about, and I'm going to have to say thank you at this point. All right, so thank you, have a nice day, and I hope you enjoy the rest of your stay in medical school.